Start with a disclosure. I wasn't supposed to be speaking this morning. But the other major speaker we had for today was going to be Dr. Ken Mendel from Harvard Medical School, and he had an emergency, so I was put on a hot seat. But I think it is going to be an interesting discussion that complements what has been said so far. And then I hope that connect the dots on what we are trying to accomplish here. So I'll jump into that in detail. So you heard earlier today about RichNet quite a bit. And if you know or not yet, RichNet is part of a much larger national program for comparative effectiveness research. And this map here and the names that you see up there are the organizations that are part of RichNet, or that RichNet is part of. PCORI, the Patient-Centered Outcomes Research Institute, funded by the Accountable Care Act. And PCORnet was one of the main projects of PCORI that's trying to build this national network of what we call clinical data research network nodes to basically allow research to be executed much more efficiently through the use of technology. So there are, as you see here, 13 of these nodes nationally, one of which is RichNet. As you can see on the map, there are more dots there on the map than the number of CDINs. But what that means is some of these CDINs cover more than one state. So in the case of RichNet here, I put our little logo on top of Louisiana and Texas at this point to highlight that. But there are some of these nodes here that they're really all over the place in the country, like with their partnerships. So you saw our partners before, you heard of them: Auction, LSU, Pennington, Tulane, Baylor Scott & White, and the GNOHIE. So then Louisiana and Texas, but other partners might be spread around. There are also 21 patient-powered research networks. And an easy way to differentiate between these two, the CDINs are more like the data nodes that basically connect all the dots on the data. The patient-powered research networks are more like advocacy groups. They're basically trying to put together their agenda for the next research that actually impacts patients directly. COPD groups, triters, and so on and so forth. So that's the idea of RichNet at this point, and that's where RichNet fits into the picture nationally. One of the major things that PCORI has come up with that has allowed this network to function nationally is what you see here, is the common data model. So that you know, PCORnet is now in its phase 2, as you heard from Tom earlier. The first phase 1 was a year and a half, so we starting phase 2, the second year of this project. And we have been through 3 versions of the common data model up to this point, even though our partners are still having challenges to comply with it, because it's not that simple to get the data that's inside of the electronic medical record transformed to a standard that everybody can agree. So it's a work in progress. But another thing that's important to be said about this common data model here is that if you compare the CDM, PCORnet CDM, with the FHIR resources that you heard Josh talk about, you're going to see a lot of similarities there. I haven't looked at the list of the resources yet, but I think probably 90%, if not all of these tables and elements are covered on the FHIR specification. I probably need to verify that and check exactly, but I know that patients are there, that the encounters are there, the demographics, basic demographics. So there's some overlap here that's very useful. The other thing that I want to highlight here is the top right corner here, the demographic table. As you can see there, there's a ton of information there. So this is what we call a limited data set based on HIPAA specifications, which means basically that you're looking at this data, you're not going to necessarily be able to identify the individuals that are here. The only element that's covered on the HIPAA here is dates. So you have date of birth, you have dates of encounters and diagnosis, and that could lead to some identification so that you can find out where that person went, what conditions they have, and find out who that patient is, and that could lead to some problems. But in in good sense in a way, being a limited data set helps a lot in terms of the legal agreements that you have to put in place to be able to actually contribute this data. So RichNet at this point, we are what we call a centralized node inside of PCORnet. What that means is our partners, our data partners that you heard, the 4 data partners, they're basically contributing their data to this format centrally to our data centers. So we have at this point, we're gonna have, once we complete the ingestion of all the data, about 4 million patients. I think we are about 2 million at this point, of which we classify 800,000 to 1 million of these patients as active patients. And what we mean by that is patients that have been, have had an encounter or 2 encounters in the last 2 years. So somebody that's going to the doctor often. So there are probably a lot of people here. I think Tom makes a joke that the folks that came to New Orleans, to Mardi Gras 5 years ago, and or maybe to St. Patrick's and tried to grab a cabbage and broke their finger and they end up at Tulane. Their record is here. But that's probably the only thing that we have in their record because they never came back to New Orleans after that experience. But the folks that we are really interested in working with in this data are the ones that have had several encounters recently. People that their data is recent, we know they are active patients. So this is a very important piece of everything that we're talking about here because as you heard from Josh, he had 4 main pieces in his first slide that was very important to be able to allow these reusable apps, right? One was the clinical data. The second one, authentication and authorization, right? And then the UI itself. So this takes care of that data itself, right? We basically have a format that you could basically design apps that can be reused across systems. That takes me to this, which is, might be a confusing setup, but I'll go over that very quickly. You see there on the left side the partners of RichNet basically contributing their data to a data mart inside of RichNet's data center. And you see a live CDM there representing a data mart that basically is updated nightly. So we continue to get live feeds. And there is a reason for that. And then there is a frozen data mart, the blue one, that we then are going to be using for data analysis to characterize that data, to check the quality of the data, and do a few other things. But the reason that we have that live data is due to that sync app that you see up there and the tablets. So that's a technology that we have developed at RichNet, where we have tablets installed inside of the exam rooms, and we are able to sync a patient record that as you know, you'll notice on the CDM is not identifiable, but we have a process by which when the patient is sitting in the exam room, the nurse has a way to click on their record in a link and execute that tablet, basically passing some piece of information to RichNet data center that we know which patient is sitting in what exam room at any point in time. And basically we can hand off that tablet to that patient, and there is something that they're gonna have to interact with at that point. And I'll go through some examples there. But that's the reason why we had that live data set, that data feed, because we wanted to make sure that we are getting the new patients that are being registered in the organization and their live data available to those apps to basically make a determination of what content we want to deliver to them. On the top there, you see the PCORnet queries, and it's an important point here that highlights why the common data model is there. The whole idea behind a network like this is that we can actually identify patients nationally using the same model. So you can kind of make a definition, a definition early on in a specific research project if there is a population there that can actually participate in that research. There's a lot of savings in that and efficiencies in terms of making that identification in a common data model. The traditional model would be for each one of the organizations to basically dig up inside of the EMR, looking at data that really does not comply with the same standards and try to find out a population that could or could not fit with that profile. So you might be able to engage a research site to do a project, and at the end you might not be able to enroll anybody in that research. And there's a lot of time involved and money, there's a lot of failure that takes place in that type of process. So when you see drugs development that cost $1 billion, there's not that this is a big piece of that process, but there's a lot of cost involved in identifying individuals that qualify to a study and actually recruiting them. So the PCORI queries there in this standard format nationally is a very important piece of the process. I won't talk much about this, but you see this black box here in this process here. As you notice as well, the common data model doesn't have identifiable information, but since most of our partners are in New Orleans, we needed to figure out a way by which we can match their records and merge them. Because we know that there's at least a 20% overlap. I have been to Tulane, I have been to LSU, I have been to Washington several times. My records are all over the place. How are you going to find out my records between these different systems and data that came in if you don't know who I am? So we have a process by which we hash the identifiable information and match that information. Is a secure process that has been vetted nationally. And again, I won't get into the details, but the whole goal of that is that we can match the patients here, combine their records, and that could allow for a much more advanced way of performing research. Again, there's a lot to be said in the research there, but that's not the point of the discussion here, but at least I want you to see this picture and understand what's going on here. In the end, what we're talking today here, it's something like this, and the order here might not be perfect, but the vision that I have in my mind and that you can imagine as well is that on one end there is the common data model, there's that standard data format. And on the other end there is your app that might also be using the FHIR resources to be able to access that data, the smart APIs or auth to authenticate your app, but basically sitting on top of that common data. And truly being apps that can be reused across sites. You heard Josh well with the 1,200 EMRs nationally, and there are a lot of challenges there with a data model that's basically still changing, on the back end. But we believe that the common data model brings an opportunity to do these types of apps, reusable apps today. We see that ONC is pushing for the standardization of the elements inside of EMRs. I believe that's still going to take quite a bit of time, but it's there. So this brings an opportunity for today to build apps that can really use the same format and data across sites. And if you think in terms of PCORNet, I mentioned that we have RichNet here, and I did mention that we have 2 to 4 million patients in that data set. And if you think about the other 13 networks, I think we are one of the small ones. I can probably say that there's about 50 to 100 million patients represented throughout PCORNet. So if you think in those terms, you basically can imagine a situation that you're basically building an app that's using this model of FHIR Smart and the common data model that now can be pretty quickly exposed to 100 million patients nationally. So that's the opportunity that we see right now, and that we hope that the developers start imagining that as well. Dr. Shu mentioned how one of the goals of the CodeFest is to actually, entice entrepreneurship. And what I'm trying to say here as well is that there's a possibility that building an app in this stack of platform, would allow you to commercialize something that could become very powerful. One thing that I believe, and I believe that the folks at ULL also are envisioning as well, is that healthcare apps are not that simple, right? You might be a great developer and not understanding much about the medical data, or you might know a lot about the medical data and not know much about this stack. We're hoping that we can connect the dots of the physicians and developers that can maybe work together to basically understand and have work on those challenges and build apps that really are powerful, that can affect the lives of some people out there. So, and that also, of course, there has some commercial implications. It could be of value to many others there. What these diagrams have representing here is the infrastructure that we put together that is being provided to you, the developers of the Cajun CodeFest, so you can build your apps and compete on this. Basically what we did, you saw the previous diagram talking about how we ingest the data and we expose that data. But basically, we use our common data model, the data that we have, to basically cut 300 patients out of that data set. And then we use a process called date shifting to completely de-identify that data. So I told you earlier that the only element that was, identifiable information was dates. So we used an algorithm to keep dates with the same format that can be used by our app. But if you look at those dates, they're not real anymore. They might be talking about a patient in 1830, and you don't know, you don't have a real date on when those events took place to know what patient is there. And then we exposing those 300 patients to this stack here, the I2B2 model of data with the REST API and the authentication, the OAuth authentication that basically allows you to build your apps, authenticate to this stack, and execute and build something that you can actually test with the data that's available. By the way, these 300 patients, specific diabetic cases, as you heard from the Dr. Shu's talk, is the goal of the Connect-a-thon to build diabetic-based apps at this point. And we are hoping that with the sample data, you can test out a few things truly that then can be transported to a true CDM by a health system, one of our partners, or any other CDIN nationally. And that app can actually go into production and be used. All right, so this is one thing that we're thinking here now in terms of this commercialization, right? You can build apps that are, running inside of an electronic medical record, like you heard from Josh, on a platform like a 2B2. You can be building apps that are actually inside of a web portal or other portals out there, or you can build apps in mobile devices as well. In our case, you heard about our tablets that we have in exam room. I would love to have some folks to come up with some great ideas and build apps that we could actually deploy within the health systems right now that we have, and I'll go into a little bit of details on that. And what we have going on at this point, this is the status of our pragmatic trial app suite. So we have deployed in 16 clinics about 226 tablets at this point. We are about to get to 1,000. They are, in our warehouse waiting for deployment, but this process is growing continuously. And the way that we have envisioned this is that is a tablet system that's EMR agnostic, meaning we don't know and it shouldn't matter what EMR is being used. It's looking at the common data model, but we do need that connection between the record that the doctor or the patient are seeing at that point in the clinic to be linked to the tablet. It's integrated in the workflow, so that the way that we frame this is we spend quite a bit of time talking to our partners. It's like, we want to do this and have a way to recruit patients into research projects more efficiently. You heard well from Dr. Rao earlier how time-consuming and expensive it is to find what patients qualify to a study, contact them, get a clinical research coordinator to meet with them, explain what's going on, getting them involved. It's very expensive and time-consuming. Our goal here was to build something that we can identify, pre-identify who qualifies based on the common data model. And when they show up in the clinic, they actually can be exposed to a content that's trying to basically get them engaged in a specific study. If it is a high-risk study, it doesn't mean that we're going to enroll them in the study, but they're at least going to get their contact information so that the CRC actually can talk to them and go through the process of engagement. And that's very helpful. You save a lot of time by just doing that, by just knowing that, yeah, this sounds like a good idea. I have that condition. I'd like to participate in this and learn more. So we started with that mindset. And we came to our partners like, where is the best location to do this? And we thought about doing it at the registration desk and the waiting room. There are challenges there because the patients, they're going to be exposed to maybe some video and audio, some media, multimedia resources on the tablet when we're trying to explain them what this is about. Or even if there wasn't video and audio, they're sitting in a waiting area, and people know now that if you're being contacted for, let's say a HIV study, is because you are HIV. So it wasn't going to be appropriate to have that in waiting room. Besides the logistics of handling tablet to folks, and they go sitting in the waiting room, somebody has to pick it up and bring it back, singing the records to a specific tablet. There were a lot of challenges there. So we came up with this idea, let's put this in the exam room. And the doctors were really concerned about that initially, because the time in the exam room is very protected. There's a lot going on that needs to take place there. So we needed to make sure that something that we're going to do was going to be very efficient. And we came up with a process to sync these tablets to their record that takes basically 10 seconds, 15 seconds. And that the processes that actually run on the tablet to the patients are about 4 minutes. So we basically were trying to target that time where the nurse or the MA finishes their walkthrough, with the patient and says, I'm going to go get the doctor, just wait here for a minute, and they leave the room. That's the time that the patient is going to engage with the tablets. So that's how we envision this, and we believe that's it's working well. So that quickly syncing the tablet process there, and it has been really developed with our partners. We didn't build something and just try it out. We talked a lot with the patients, with the physicians, to really see what would really work, and there are refinements that still take place over time. So this basically is describing that sync process. Somebody comes to the registration desk. Once that happens, we get a HL7 message on our end saying, this patient ID is sitting here in the waiting room right now, and he's about to enter the exam room. Do you have any content to expose to this patient? And we respond yes or no. And then at that point, the nurse basically gets a link inside of the navigator, in the case of Epic. And they have several things to do, right? They have to take their blood pressure, ask a few questions, blah, blah. At the end, there's a link there to activate the tablet. And that's the time they are going to walk out of the room. They click on that link, and if there's a content, the tablet is going to come on, and they're going to tell the patient, could you take a look at this tablet here while I'll get the doctor? There might be something here interesting to you. And that's when they leave the room. The patient responds. They enter their date of birth to confirm, based on the records that we have. And if they enter that incorrectly 3 times, the tablet locks up. If they are in halfway through the process and they put the tablet down, it locks up again in 2 minutes, and somebody needs to enter their date of birth again. So there are some measures there to make sure that somebody else is not looking at that data. But in the end, we basically kicked off the process of interacting with that patient at that point. And we have several apps that have been built in this process. We have a division here between patient apps and research apps, and we have patient app modes, where some modes we're trying to recruit patients, and other mode we actually try to engage with them. And I'm not going to go into the details here, but we have several of those running right now, and we have also some for the researchers to be able to do more efficiently manage their research processes. And I'm going to go over a few quickly. But I do wanted to mention that if you want to hear a little more about this, to go to the Connect-a-thon.reachnet.org. There are a couple of speeches there that we have recorded in the past, at ULL, another one from Josh, that you can review everything that you're hearing here today. And we should be posting the other ones as well. But some examples here. We have something called Health in Our Hands, so HIO, which basically is a patient registry that somebody says, yeah, I'm interested in helping with research. Here's my contact information. If we find out, maybe right now they don't qualify to a study, but in the future when they do, we have their phone number and an email. We can send them a text message and say, listen, there's something here that might be of your interest. And they click on that link. They're going to be taken to a portal. They need to sign in, and then they're going to be able to interact with that content. If they're interested, they say, yeah, I'm interested in learning more. Then the CRC is going to contact them directly and start that process of engagement. So this Health in Our Hand function basically is doing that. So they watch a little video, they consent to participate, they give their contact information. And we also ask them a few questions, and they go through that basic survey. The consumer health is basically where we can kind of engage with these patients and do a few other things that might be interesting. Imagine that a good example that we had from one of diabetics doctors was that for a certain group of patients, he would like to give them a speech about what they need to do in terms of their eating habits and their physical health. And he told us that he kind of repeats that quite a bit to their patients. But what if we record him in a video, basically giving that 15-minute discussion about what they should be eating and what they should be doing? And when these specific patients show up in the clinic and are waiting for him, they could be exposed to that content. And he was like, this would be great because it does two things. Well, the patients are not that upset with me that I haven't showed up yet. They're waiting in the exam room for too long. And the second thing is that they're actually learning something. So when I walk in and I know that they have just gone through that process, I can just re-emphasize and save a bit of time. So they're very excited about this idea of a consumer health. There's something else that we have built that's going live right now called the Command Center that basically we put on the hands of the physicians and the health systems. And that solution, basically, the whole intent is that you could deliver one of these contents without ever writing one single line of code. You can basically say, I want this video, I want this text, I want a few questions that I want to ask to these patients, and I want it to go to these specific clinics and these specific exam rooms. And they execute that flow. Then they can also, using I2B2, make a query, a selection of patients. What patients should receive this flow? And those queries get connected to that specific flow that they just built. And when the patients show up, the tablet comes on, they're going to be exposed to that specific content. So we thought that would be very helpful because there are not that many research projects out there right now that we're working on. There are going to be many, but even so, when you look at the population of millions of patients, the chances of having some content for patients in a study are very small. So we wanted to have our ability to basically provide more resources instead of having our tablets accumulating dust in the exam room. So we built that command center to give it to the health systems to say, build whatever else you want to expose your patients to do. It could be a survey, you know, if you want to ask them about the quality of the last visit, or it could be a video about how you want to instruct them about their health, or something very specific. And we have a few other modes, the recruitment that you heard about, that if you qualify to a study, like we have a study right now called Weight Smart that basically is recruiting patients that fit some specific category, eligibility criteria. And what we're basically doing, we're giving them a smart scale that's cell-enabled, where they take that scale home and they weight themselves every day. And there's not really a big value here in this study, except that we are trying to learn how the technology works with all these pieces. So the patient takes the scale at home. We divided this in two arms. We're recruiting 200 patients. One arm is basically getting a text message every day asking them, did you weight yourself today? And another arm is basically getting a text message every 2 weeks, I believe, and reminding them to weight themselves. Every time they weight themselves, we get that data automatically fed to us. And again, I guess a research question here would be like, does text messages really help people weight themselves, and does that has an effect on weight? I don't expect any breakthrough that, but at least we are trying to find out if all these pieces of the technologies are working as they should. And we have found some great things, and it's working quite well. Another piece that comes with this specific research that we wanted to pilot was the ability of the clinical research coordinators to help the patients that are involved in this process. So I think I'm going to jump these. This is just the ability of send surveys to patients to their mobile devices or email. They can answer this if it's in any mobile device, so they can answer their surveys wherever they are. But this is the piece that goes along with the previous screen on the Weight Smart. So this is the Recruiter app. So for that specific study, we have a process that's set up in such a way that the patient comes to the clinic, they get exposed to this specific study, they say, I am interested, or they say, I don't want to be involved, or they say, I have questions, I need help. And this platform here is a web-based platform that the research coordinators log in and basically say, what is the status of all the patients that have been contacted about this study? How many people need help? How many people have been consented for follow-up? How many people are scheduled to come to the clinic and actually pick up the scale? How many people are enrolled and part of the study at this point? And as you can imagine here, if you have been involved in clinical research, this is very specific to this specific research study. Every other study might require another dashboard here that the clinical research folks would use to help them manage that research. But that's where, the APIs, this platform comes in handy. Because if there are many developers there that can easily redesign this portal here to allow other research projects to be managed more efficiently, I think there's a lot of value there that we see on that. I don't want to take a lot of more time. I do believe that I have one chart here that might be interesting to see as well. This is a summary of what we have done with the tablets in the exam room up to this point. So we are doing two things there. We are enrolling patients in our registry, and the second thing, we're asking them to ask questions. And we kind of evaluated how this is taking place. The tablets that we are using, we also tracking all the analytics of what's going on. Every question, every touch that the patient execute on those tablets in an exam room, we are able to visualize that and know where somebody watched the video and up to that point they were like, well, I'm not interested on that. Or some people did and they answer yes, but then when they were answering questions, they stopped. So we track all these steps throughout the process so we know what's going on so that we can fix things as appropriate. But what this is saying, with those 226 tablets in 16 clinics here at Oxna and Excel, and within 6 months, we have been able to basically enroll, and these numbers are much higher now. As you can see, it's a growing rate as we improve the technology. But we were able to enroll 2,500 patients in that Health in Our Hand registry within that period between March and October. And we noticed as well that some people might not be willing to enroll in the registry, but they were interested in answering the survey. They had no problem answering the survey, so a much larger number of people. And this is, if you haven't been in clinical research, you might not understand how important this is. And basically, in a few months, we were able to enroll 2,500 individuals in a specific project. I could go into some examples out there, but I know of cases that can take years, 3 years, 4 years, to maybe get 100 people enrolled in a research project. So it's a much more efficient process, at least for research. But I want you also to keep in mind here that although ReachNet is interested in running research projects, in building an infrastructure to allow research to run more efficiently, it doesn't mean that the data on the common data model and this platform that you heard about of FHIR and I2B2 Smart can't be utilized for other things as well, like the examples that Josh provided in terms of building some tools that maybe use that same data model that's now standardized, that could basically expose data in such a way that really is helpful for the patients themselves and for physicians. I'm sure I don't know about you, I have my examples at home. Even though my wife is a healthcare professional, once in a while she gets lab results in her phone now, and she has to Google things around to find out what they mean really. So it's kind of the example that Josh gave early on, that you get those results in text format with numbers and things that you really don't understand. Just transforming that data to something that people actually understand is very powerful, and that will be very powerful for patients.